fourth wave of the US overdose crisis, rapid shifts, structural drivers, and systemic inequalities in US drug policy. And with this talk, I kind of wanted to zoom out and give like a really high level of the US overdose crisis and highlight like a number of different areas that I've been working on that I think are really important. And I think this is a good time for this sort of a talk because so many things have changed in the past year or two. I mean, like it's just a really, really kind of dynamic time and a really important time to be talking about overdose. And so thanks for the opportunity to talk about this. So I did want to give everybody a heads up in advance that this talk does discuss distressing themes such as drug-related deaths, incarceration, and racial and ethnic disparities. And it's just something to keep in mind moving forward. And throughout the talk, I'm going to use QR codes for references. So anytime I show data or papers, if you want to grab the paper, you can just open your phone camera and access it that way. So since this, I think a lot of the people in the audience are students, I thought it might be helpful to just give a little bit of some background about my trajectory through academia and how I've gotten here, give some context. So I did my undergrad at the University of Vermont in anthropology, really focused on medical anthropology and kind of like in global health. I did a master's in public health at the University of Washington, where I also did a 3-year data science fellowship at the Institute for Health Metrics and Evaluation. So I really went from like full ethnography, fully qualitative, really to the other end of the spectrum, to fully quantitative. And then in grad school, I kind of wanted to mix the two. And so now I'm at UCLA and I applied into the MD program. And then when I started doing some research, started meeting some really cool mentors and decided I actually wanted to do a PhD as well. And so I ended up applying into the MD PhD program, where I'm now about 6 months out from finishing a PhD in social medicine. And so now I do sort of mixed methods research. A lot of it is ethnography, so intensive qualitative participant observation research with people who use drugs in Tijuana, Mexico. And then I also do a lot of kind of data science and more quantitative stuff. And just because this is such a high level talk, a lot of what I'm going to be showing today is quantitative, but I'm going to try and mix in some important qualitative details as I go. And obviously happy to take questions about anything at the end. So the US overdose crisis is a uniquely American problem. So this is a graph looking at overdose death rates from 1990 to 2019. So this is all pre-COVID. And you can see these are the top 10 countries for drug overdose deaths globally. And you can see United States here at the top. And so even before everything got a lot worse during the pandemic, the US was already had twice the per capita overdose death rate of the second worst country and something like 20 times the global average, right? And you can see actually during the past 2 years, this number here, I think in 2019, we're at about 20 overdose deaths per 100,000, and this is now up to 30 and rising, right? So this is a really, really uniquely bad problem in the United States. And I think it's uniquely important to think about here. So this data here is from this paper that came out in Science a few years ago, and they made this claim that actually here on the left, you can see the overdose death rate from all of these different substances. So prescription opioids, heroin, fentanyl, synthetics, and cocaine, and all of these different drugs. And you can see, you know, the kind of shifting pattern of which drugs people are overdosing on and dying from. But if you look on the right, you can see this smooth exponential increase. And so the argument here is basically that the overdose crisis has been getting exponentially worse for the past 4 or 5 decades. And there's really no sign, there's no period here where things have been getting better or even really staying flat for any meaningful period of time. So people like to talk about that there are, quote, 4 waves of the overdose crisis, and I'm going to briefly go over what they are. So first, the quote first wave was from prescription opioids like OxyContin, and then heroin, right? The kind of the popular narrative goes that as it became harder to access prescription opioids, a lot of people moved on to heroin, and subsequently, of course, everything is moving to illicit fentanyl analogs. I'm going to talk about that in a lot more depth. And now the quote fourth wave, which is really a very recent term, refers to the mixing of fentanyls and also stimulants like cocaine and methamphetamine. And I think it's important to note that really prior to these four waves, there was a very significant cocaine overdose crisis, which is not usually grouped in here, but I think really that is kind of the first wave, or wave zero, if you will. So I think beyond just mixing stimulants and opioids, the fourth wave of the overdose crisis can really be defined by these key criteria in my mind. So first, it's driven by illicitly manufactured fentanyls and synthetic opioids. Second, these are deaths that involve potent synthetic analogs in many different drug classes, not just opioids, and specifically the polysubstance use of different substances. So people mixing opioids and stimulants and many different kinds of drugs. And finally, counterfeiting, meaning people think they're buying one thing, but they're actually being sold something else. Thirdly, extreme exacerbation during COVID-19. I think probably many of us know that things have gotten a lot worse over the past 2 years. And finally, sharply rising racial and ethnic disparities. So I'm going to quickly go through kind of each of these areas, and then we're also going to get into some solutions and kind of structural analysis about what's happening in our country. So the first thing is fentanyls, right? And I think probably a lot of people in the audience know that fentanyls are a family of synthetic opioid agonists. They're opioids that are many times stronger than traditional heroin, up to hundreds or thousands of times stronger than traditional heroin that's produced agriculturally. And illicitly manufactured fentanyls have really changed the risk environment for people who inject drugs. They've made it much more dangerous to use drugs. And there's many reasons for this, but I think one of the most important ones is just that it's so strong, and so it's kind of easier because of kind of low standards, like lack of regulation. It's easier to get a very, very strong dose without knowing it. There is also this additional effect where fentanyl has a shorter half-life than other opioids, and so requires more doses per day, which can oftentimes lead to more injections per day, and therefore more injection-related kind of morbidity and complications. And fentanyl was initially concentrated on the East Coast of the United States, but has been spreading west, right? And so I think we're really seeing this over the past couple of years in California. So for example, here's a graph of any opioid overdose-related deaths in California, where I think many of us work and live. And you can see that overdose deaths were actually fairly flat from the early 2000s through the past about 2016. And then it's really just the past 5 years that overdose deaths in California have skyrocketed. And this is a pretty different picture than what you see nationally, where, for the past 20 years, things have really been going up, but much more so kind of in other parts of the country. But really, we're seeing this now in California. And if you actually break down which drugs are leading to these overdose deaths, you can see that the rise is almost entirely accounted for by fentanyl-related overdose deaths, which is what we're seeing now. So I think a really important aspect here is this thing called the chocolate chip cookie effect. And I guess that probably a lot of you have heard of this, but here's some data that I think illustrates this really nicely. So here what you're seeing is some data from British Columbia, where they have really good drug checking data. So people will submit samples and they will do chemical analysis, and they can break down what's actually in the drugs that people are consuming. And here you can see on the y-axis the number of samples. This is a histogram, like this is the density of the drugs that people are consuming. And on the x-axis, it's fentanyl concentration. So what percent of the drugs that people sent in was fentanyl? And you can see like most people are getting stuff that's like 5 to 10 to 15% fentanyl. But there's this long tail here where people are submitting samples that are up to 75% fentanyl, right? And I think some of this is coming from the chocolate chip cookie effect, which is basically the idea that fentanyl is this very, very strong drug that needs to be kind of mixed with other powders, right, to be weak enough to be sold to somebody. But the problem is it's not always mixed very thoroughly. So you'll have a lot of, add a little bit of fentanyl to a lot of something else. And it's not always mixed homogeneously throughout all of the powder. And so you might end up with some samples that are very strong and some samples that are a lot weaker. And you can see that visually in this graph. So ultimately, this is just a problem with lack of kind of production standards of this product that a lot of people are consuming. where some people, I mean, it's like, imagine you went to a bar and the alcohol concentration in the drink that you were buying looks like this, right? Where like most of the time it's a 5% alcohol IPA, but then once in a while it's a 75% alcohol IPA. And the only way that you are able to assess that is by actually drinking it. You could imagine we'd probably have something really similar in terms of alcohol poisoning to what we're currently seeing with fentanyl. So the second characteristic is potent synthetic analogs and polysubstance use and counterfeiting. And I think this is really important. So polysubstance use is on the rise. Probably this is something you guys see when you do harm reduction work, that people are mixing drugs to a much greater degree than they were before. There's a lot of intentional, at least a lot of the people that I have worked with intentionally are mixing opioids and stimulants because they like, it offers things that they're interested in, that they enjoy, that they like, or helps them get by. And there's also a lot of non-intentional or non-optional mixing of synthetic opioids with synthetic benzodiazepines, xylazine, which is a tranquilizer I'm going to talk about in a little bit, and a lot of other stuff, right? And so I think this is important, where there are some markets where people don't have any choice. Like the only thing you can get is benzodope, where fentanyl is being mixed with novel synthetic benzodiazepines. But people also kind of respond and grow to like these mixtures, even when they might be more dangerous. And so these things often start out kind of non-optional, and people may not even know what they're consuming, and then can become kind of mainstreamed. And here's just a graph, again, with data from California, because that's where I think most of us are. And you can see, and this is overdose death data. I think what we'd really like to have is data that people, other kinds of data about what people are actually using. This is just what people were using when they died. It's kind of a proxy for what we really care about. But you can see, again, the rate of people mixing stimulants and opioids when they die has gone up like tenfold over the past kind of 15 years in California. So now I want to do a little mini case study about xylazine, which I think really exemplifies kind of some of the dynamics that have been happening over the past couple of years. So this is a picture of this ethnographic field site in Philadelphia, where I have been involved with the ethnographic team. I haven't actually conducted the ethnographic work there myself, but I've been involved in doing some data analysis and kind of putting their ethnography, their like long-term immersive qualitative research into conversation with some data, quantitative data analysis. So xylazine is a veterinary sedative, which is not approved for human consumption because it has some kind of concerning side effects. So the FDA declined to approve it. And it was noticed by the ethnographic team in Philadelphia in the late 2010s. And this kind of prompted us to analyze those ethnographic data and also do a systematic search for other kinds of data about xylazine emerging from all over the country, specifically in medical examiner and coroner's offices, because you can't like go into CDC databases and look up xylazine death rates because they're not systematically collected, but we were able to go find some other data sources. So first, I want to share some ethnographic data about xylazine uses and risks. And I think this is really helpful for understanding the demand for xylazine. Like, what is it that people like about it, right? Is it just that sellers like it for some reason, or do people who are consuming it also like it? So this is a quote from a 30-year-old male, lives in Philadelphia, injects opioids and methamphetamine. And he said, "I like it because fentanyl is such a short-lived high. The nod is over real quick and you get sicker faster. See, the trank extends the high. It gives the dope more of a heroin-like effect." Excuse me. And so here, basically what we're seeing is fentanyl has this really short half-life, right? This is one of the most common things that people complain about with fentanyl, is that they have to be using way more often. And so if xylazine is able to somehow extend this high, this would be kind of like a natural market response to this characteristic of fentanyl. However, there's also a lot of risks and a lot of people don't like it. So here is a quote from someone else who said, on the risk of soft tissue infection, "I got some friends out here that got really torn up by it. They got holes in them, abscesses. Basically, it's like the body is rotting. People here are losing limbs like with gangrene. Whatever they're doing with the trank, everybody is getting these scabby sores all over their bodies." On the risk of overdose, this was from a harm reductionist in Philly. And they said, "The number of people I was reversing, meaning administering naloxone to, was definitely going up. there were people who would become only minimally alert and be only slightly responsive to Narcan. So that definitely concerned us that something different was happening, that there were non-opioid agents involved. We did a lot of Narcan training, and we had to focus more on the necessity of doing rescue breaths instead of just Narcan. So subsequently, right, so this is the ethnographic data we observed in Philadelphia. This kind of clued us into this is something important. We decided subsequently to go and look for quantitative data from all over the country, because basically we don't have the capacity to go do ethnography all over the country, which I think is perhaps what we really would have liked to have done. So we were able to get the coroner and medical examiner overdose death records from, I think, about 15 different places, and we found xylazine in 10 of them. So it's starting to become common. And these places were actually from all major US Census regions. So you can see we had data from San Diego, from Phoenix, also from the rest of the country. And what we saw is that the prevalence of xylazine being involved in overdose deaths actually rose from about 0.5%, so 1 out of every 200 in 2015, to almost 7% in 2020. So this is kind of exponentially starting to take off, I think, in a way that we often see in the overdose crisis, that things kind of start small and then they take off and kind of spread like wildfire to the rest of the country. And what I like about this case study is that, you know, things are changing so fast in the overdose crisis. And I think ethnography, like having ethnographers embedded in communities, and actually I think harm reduction plays a very similar role, right? Especially harm reduction that is then kind of tied to kind of research and data production, I think is this really nice way of noticing something as important is happening and being able to quickly get the message out and figure out ways to see if the same thing is happening in other places around the country and around the world. So the third trait is extreme exacerbation during COVID-19. So I think probably by now we all are aware that overdoses have really been spiking over the past 2 years. But there was actually a time where this was not so commonly known. It was known, however, among a lot of frontline harm reduction organizations. So I heard from a lot of folks who were saying in kind of the earlier months of 2020, like, hey, something different is happening. Overdose rates are going way up because people know what's happening to their friends, the people they work with, their loved ones, right? But we didn't have any data from the federal government about this for approximately 8 months after overdose deaths started to skyrocket. And so, the reason for that is because there are really some kind of profound challenges with overdose surveillance in the United States, and it has to do with reporting lags and data infrastructure. So this is a graph from the CDC, and it shows the percent of death certificates that are available in the kind of central CDC system by number of weeks after the death. So you can see for something like heart disease, right, or for all causes, like the average, you can see that actually after maybe 2 or 3 months, they've got about 90% of those deaths that have kind of trickled into the system. And suicides are a little bit worse, injuries are even worse, and drug overdoses are by far the slowest cause of death. And this is because there's usually a kind of a provisional coding of these deaths, but the coroner, the medical examiner has to wait up to, I've heard of like 8 months for the toxicology to come back. They have to go do an investigation. There's a lot of lags, right? There's a lot of kind of slow elements built into the system. And these are not required to be slow. These are slow because public health is underfunded and poorly coordinated in the United States. There are plenty of other places where these kinds of lags don't exist, and there are finalized kind of overdose death statistics maybe a month after the event happens, right? But this is kind of the context we're working in. So this is an article that I was involved in that came out just before there were any provisional data kind of highlighting the sharp increases in overdose deaths during the pandemic. And what we were trying to do is we were kind of frustrated. We knew that all of these deaths were likely to be happening. We were frustrated because we didn't have access to any data from the CDC. So we went and looked for a different data source. And we ultimately ended up using something called NEMSIS, the National EMS Information System. NEMSIS is a registry of emergency medical system records that contains about 90% of US EMS calls. Excuse me. And it's available on about a 1-week lag. And so what this means is that we were actually able to track the rate of overdoses occurring in EMS observed overdoses. And we were able to show that here. So on the y-axis, you can see kind of as a rate of EMS calls, how many of those calls had overdose deaths. And you can see the baseline and previous years in black and orange. And then in 2020, you can see the sharp spike occurring right at the onset of the pandemic. So right at this dashed line, pandemic starts, there are lockdowns, and there's this really steep increase, this totally unprecedented increase in overdoses. And of course, subsequently, we would see deaths from the CDC, kind of like all observed deaths from the CDC that would confirm what we were seeing was in fact real. And this tells us, like, instead of waiting 6 months to find out the number of overdose deaths from the CDC, there may be other ways that we're able to kind of know what's happening more quickly. Subsequently, we put out this follow-up study where we were able to go into a little bit more depth. And so here we were able to more formally show that EMS observed overdoses actually are a really good proxy for total overdoses. And you have this EMS overdoses on an only 1-week lag. And so what you're seeing here is EMS observed overdoses on the y-axis, total overdoses on the x-axis, and you can see there's a really tight correlation there. And so some of the work that I'm involved in moving forward is how can we kind of use the EMS, what we're seeing in the EMS data system to kind of nowcast to predict what's going to happen in total overdose numbers, or predict what is actually happening now, but we simply won't know for the next 6 months. The other nice thing about NEMSIS data is that they include all of these other social indicators which we care about, which are often not included in provisional overdose statistics. So, the CDC puts out these rolling 12-month provisional counts now. This is a kind of a new thing they started doing recently, and they have an about 7-month lag. But unfortunately, they often don't include race and ethnicity and other things that we care about that we think are really important. So the NEMSIS data do include race and ethnicity, poverty level, and other stratifiers. And so we were able to kind of quickly track social disparities in overdose. So here what you're seeing is the percent change from 2019 to 2020 in EMS observed overdose deaths by social group and by poverty of the zip code where the death occurred. And you can see that the biggest increases were seen among Black and African American patients, among Latinx patients, and also among people living in medium and high poverty areas. And again, subsequent data have come out that have confirmed these findings, but we were able to see this like a week after it happened, instead of waiting 6 months or up to 2 years for data. So here are some of the data that have finally come out from the CDC showing the kind of real monthly increases in overdose during COVID. And I just want to point out, so here you can see the number of monthly deaths on the y-axis, and you can see the month on the x-axis, and year is shown by color. So you can see kind of 2015 up to 2021, and each year deaths are going up. But before the onset of the pandemic, the worst month ever was about 6,000 deaths. And as of, you can see that like April and May were really, really bad months. And May 2020 was the first month that over 9,000 people, and the only month still, I believe, to date that over 9,000 people died. But really concerningly, we're not seeing things come down, right? I think I've shown the first 4 months of 2021 here. So we're a full year out from like this big peak, and we're still almost at the level of this big peak. Like it's not like I think a lot of people had hoped, okay, the lockdowns receded and things are going back to normal. Overdose deaths are going to go back down at least to 2019 values, which still be astronomically high, but at least would be kind of, there'd be a return to normal for us. And unfortunately, we're not seeing that. And I think there's this idea in people among people who study overdose that it tends to be this kind of like ratchet wrench effect where as things get worse, they just stay that level of bad for a while and then they get worse and they stay that level of bad. But we have had, even now, we've never really had an example of deaths going down by 10% or something like that. So the last characteristic that I want to get into is sharply rising racial and ethnic disparities. So data from the CDC have finally come out that are broken down by race and ethnicity for 2020, and they're summarized here. So you can see, let's start with the bottom panel. So this is the death rate, again, like we've been looking at for the whole talk, but now broken out by race and ethnicity. Latinx in green, African American and Black in blue, white non-Hispanic in red, and then Native individuals in purple. And you can see that by far the biggest increase in 2020 was among Black and African American individuals who overtook the overdose death rate of white people for the first time since 1999 in these data. So you can see, for example, like in 2010, the white overdose rate was about double the Black overdose rate, but since 2012, every year overdose has gone up more among Black communities, and now in 2020 has flipped. Also, the highest overdose death rate in 2020 was among Native communities, by about 30% higher than white individuals. And here on the top, you can see the annual percent change year to year, broken down by racial group. And so we can see that for all groups that we looked at, 2020 was by far the worst year that we've ever seen. But it was not kind of proportionate, it was disproportionately a bad year for certain groups more than others. So this data is publicly available in a preprint. We had to wait so long to get these numbers from the CDC that we couldn't bear to wait another potentially year to get through the peer review process. And so my co-author, Helena Hansen, and I decided to just put this out as soon as possible in a preprint. So here's the link. These data are public, although they haven't been published in a peer review journal yet, but they will be soon. And we also decided to kind of contextualize a little bit more about these data in this op-ed that was published recently in the LA Times, where we try to argue that actually the original title before the venue made us change it was like far from a white problem, right? Trying to counter this narrative that overdose is a white problem, which you still see all over the place in media, this idea that like, oh, like this is this unique public health problem that actually affects white people, right? And this has been a very prevalent idea. I think this narrative has always been problematic and has always been contested by many people and many scholars and activists for various reasons. It just hasn't been factually correct. Like, for example, there's always, as in the data I've just shown, you can see that there's always been equal or higher rates among Native communities, but that has certainly not been kind of reflected in this narrative. There's also disproportionate, even when white overdose rates might have been higher than, for example, Black overdose rates, there were still vastly disproportionate harms for minoritized communities by US drug policy and by kind of the effects of addiction in society, even if for this one indicator, that was not the case. But now this white problem narrative is really not the case. And I think it's important to kind of get the word out about that as much as we can, because people's ideas about who is vulnerable to overdose actually have a lot of power, right? Like, these people think like, oh, overdose is not a problem in my community. They might be less kind of invested in doing something about it. And I think in general, it's important that we raise awareness about this now, as overdose is spiking all over the place, but really spiking in ways that kind of worsen racial inequities in our country. And there's this really important opportunity, I think, where the goals of racial justice movements really now, I think, align in a lot of ways with what we need to be doing to prevent overdose in our country. So That was a lot of dense information. Maybe we can all take like a 10-second break and, stretch out a little bit and then dive into some structural drivers and solutions. This is, of course, a massive topic that I can't do justice to in just the 5 minutes that I have left, but I'm just going to try and get into some big areas where progress is being made and can be made. And then I think we can perhaps get into some more details in the question and answer if people are interested in that. So again, we're talking about structural drivers of American exceptionalism, right? I think this term gets used a lot to talk about what a weird country we live in many different things, but especially in overdose. So here's just a reminder that the US has an overdose death rate that's probably now 3 times worse than the second worst country. This problem has been accelerating exponentially for 40 years, and we are one of the wealthiest countries in the world. Why have we not been able to even make a dent in this massive crisis, right? What's going on here? The first thing I want to say is, if in many narratives in the media, people will point to the overprescribing of prescription opioids as the causative factor, right? That's the reason why, because the pharmaceutical industry in the United States is so corrupt that they were able to kind of hoodwink our population, and that's the reason the overdose crisis is so bad. And I'm here to say that is a scapegoat, right? That is a vast oversimplification of what is happening and what has been happening. And so if you hear someone basically say, the way to solve the overdose crisis is reduce opioid prescriptions in the healthcare system, you can say that's completely wrong, right? We've actually probably gone too far. There's absolutely a moment where opioid prescribing in the healthcare system was one important factor that did lead to addiction and overdose, but it was just one piece of the puzzle. Currently, prescription opioids are involved in 50. I just ran the numbers on like the very latest data from 2021, and they're involved in 15% of overdose deaths, right? But they still occupy far more than 15% of policy responses, where all of this money and advocacy and training and time is spent on, maybe we can do all these surgeries without opioids, and there's a lot of attention on this, right? But this is really not the solution to the overdose crisis. And in fact, crackdowns have actually, I would argue, gone way too far, where they're harming pain patients and also palliative care patients. So here's an article where they looked at opioid prescription among cancer patients who are at the end of their life. So people who I think anybody can, it's just common sense that these are not patients who are at a lot of risk for developing a substance use disorder, because they're largely just in pain, right? And near the end of their life, and opioid prescribing among these people have gone way down, because there's all of these structural things being built into healthcare that are disincentivizing physicians to write a lot of scripts for opioids, even in cases where it is objectively completely appropriate. And prescribing reductions are really a blunt tool, right? And where you see this is also they're often very inherently racist and classist. So here's another article, which I think is kind of old. It's almost 20 years old now, but it was from New York, and they looked at when the prescription drug monitoring system was put into place, what happened with benzodiazepine prescriptions, and they saw they went way down, but they didn't go down among people who were receiving potentially inappropriate prescriptions. They went down to a much greater degree among communities of color receiving like very appropriate benzodiazepine prescriptions, right? And so this is like, if the goal is just reduce prescriptions, you're going to inherently reduce them among more vulnerable communities and among people who actually need them, right? And we have not been able to reduce prescribing in inappropriate ways without reducing them in very needed and appropriate ways. Here's a study that I participated in California, and it's just hammering the point that that opioids are delivered through the healthcare system to a much greater degree to white individuals than non-white individuals, right? And I think this is kind of like showing us some of the reason why the overdose crisis and kind of drug use in our country is so patterned by race. And so here on the y-axis, you can see, so each box, basically this whole kind of graph is representing the society of California. And as you move up on the y-axis, you're moving into whiter and whiter neighborhoods of California. And as you move to the right, you're moving to wealthier and wealthier neighborhoods of California. And so each box shows the percent of that zip code that receives an opioid at any given year. And so what you are seeing is that opioid prescriptions are about 300% more concentrated in high income white communities relative to kind of everybody else, right? So like 45% of the whitest kind of lowest income areas in California were receiving an opioid prescription during the study period compared to like 16% of other neighborhoods. And this is clearly not based on medical need. This is based on the way the healthcare system is set up and who is receiving medications. So I'm going to try and move quickly because I know that we are probably almost out of time. I'll say that fentanyl has really increased the risk of incarceration as a risk factor for overdose. So I would say that evidence is pretty much conclusive that if preventing overdose is our goal, then possession and low-level sales of drugs should really not result in jail or prison sentences, right? So this is kind of the philosophy of decriminalization. And there's a lot of data about this. So people are at like extremely heightened overdose risk right after incarceration, and it relates to the fact that while incarcerated, people are really destabilized. They're separated from support networks. They lose economic opportunities and typically receive like zero treatment for their substance use disorder, and then they're just kind of released on their own. It's very difficult to find housing and employment and all of these other things that people really need to be stable. And so all of that instability promotes overdose. And I would just say that to the kind of neoliberals in the audience that, you know, there is a very high cost to taxpayer of all of this massive state investment in incarceration. And we really receive like zero or a massive negative return on that investment in terms of subsequent social spending. I think it's helpful to conceptualize our response to drug use and addiction on this spectrum, where on the extreme end of the spectrum, these are all things we see in different drugs, you know, today in different countries. There's extrajudicial killings of certain people who use drugs. We see this like in the Philippines today. We have drug-induced homicide laws. We have this in the United States today, where people are charged for murder for giving their friend a drug that they overdose on. There's prison for simple possession and prison for low-level sales. I think this has really been kind of the overwhelming drug policy response in the United States over the past 50 years. There's decriminalization without comprehensive services. I would say this is kind of Oregon, right? Where, you know, Oregon is still in the United States. They do not have federal funding to provide comprehensive social services, even though they would like to. And so they have decriminalized now, but they have not been able to provide everything that, for example, Portugal has provided, which I would say is the next example of decriminalization with comprehensive health and social services. And I think a lot of the success Portugal has had comes from those services, not just drug decriminalization in a vacuum. Then there's safe supply, which is actually saying not only are we going to not just make it, we're not just going to decriminalize it, we're actually going to replace the supply. And instead of you buying an unregulated, highly toxic, dangerous supply on the street, we're going to give you that supply, but really just for people who already have a substance use disorder, right? Not for somebody who's just wants to try this thing, but for somebody who like clearly this is already a really big part of their life. And we can see that, for example, in Canada, Switzerland, there's a lot of good examples of that and have really good outcome data. And then of course, there's legalization and regulation, which we have for alcohol, cannabis in many states, and not much else except for, you know, prescription drugs. So I'll say that people really like to talk about treatment, and treatment is really important, but it's not a magic bullet. But we really need kind of structural solutions to the structural problem of overdose. The United States is a very wealthy country. We have the same GDP per capita as the Nordic countries, like Norway. We have a higher GDP per capita than Sweden. And so you think about all the things that people in Sweden enjoy, like free education, really, really good free healthcare, and a year of parental leave, although maybe that's less related, and all of these things, right? Really great housing, all of this governmental support. We have just as much money as them, but we don't receive those services. And so this, by definition, that makes us a country of extreme inequality among wealthy nations. We know the overdose epidemic has always predominated among low-income communities in the United States, although kind of some aspects of that have changed. And so improving economic, I would say this is maybe the most important takeaway actually from the talk, is that improving economic, educational, healthcare, and housing equality is really the key long-term solution to the overdose crisis. I'm going to unfortunately skip this nice ethnographic vignette for time, although I'd be happy to go back to it. I think harm reduction is really key, of course, and I know that's in the name of the organization. And there's all of these methods here of harm reduction that I would say that is a key thing we can be doing now in the apps as a kind of rapid response, hopefully until drug policy catches up. So overdose prevention sites, of course, have just started to open in the United States in a legal fashion. I think that's incredibly important. This is a way of making drug use safer when you can't give someone a safer supply. Drug checking, knowing if fentanyl is in your drugs. This is really helpful at the beginning when an area is just starting to shift to have fentanyl. But unfortunately, once the market is saturated with fentanyl, it doesn't do you that much good to know that you have fentanyl in your dope, because that's all anybody's consuming, right? And so there, you really need to know the purity. So having something like what they have in British Columbia and to some degree in places in the United States, where someone can say, you give them a sample and they'll say this is 50%. So be really careful with this, right? Or they'll say this is 5%. So this is what you're used to. I think I've mostly covered this. And yeah, so these I think are the kind of key takeaways in terms of structural solutions to the overdose crisis. Improving economic, educational, healthcare, and housing equality. Improving access to treatment is key, although it's not a magic bullet. Federal decriminalization would be a great step, and it would especially let us take this huge amount of money that we spend on incarceration and move it into services and a safer supply of substances. So with that, I will finish. And here's my Twitter and my email. I'd be happy to connect with folks. And most of the articles that I've presented today can be accessed here. So thanks so much.